the impact of existential distress goes far beyond medical assistance in dying. That, even when your numbers have climbed to, as high as they have in Canada, it's only 3 to 4%. It's actually not that high at all. But the percentage of people who experience severe existential distress before they die is probably somewhere between 20 and almost 40% of the population. So again, the quality of life and the suffering itself is really the key feature, and it's extremely common. It's very burdensome. It is, for many people, the worst symptom they experience.
Good afternoon, Dr. Downar. James, thanks so much for making time today to be interviewed on the Kernel Network podcast. You're involved in so many different kinds of things. You're a practicing physician in Ottawa. You're leading medical divisions and societies. You're a very accomplished academic and researcher. You're a very busy person. I'm really glad that you could make time. And it's been my honor to be able to connect with you in a few ways in the past in relation to my own teaching and research. There's really a lot of things that I would like to talk to you about, but I was wondering if you could start by sharing a little bit about your career.
Thank you for asking the question, and it's a real honor to be part of the podcast today. I remember when I entered medical school, there was a mentorship program, and they asked us, what kind of a doctor do you think you want to be, and is there anyone in particular type of physician you'd like to be paired with as a mentor, or somebody you wouldn't want to be paired with? And I think I wrote two things on the form. I said I don't want to be a palliative care doctor, and don't put me with a psychiatrist. And sure enough, they put me with a psychiatrist, and here I am. So my interest, I think, in sort of being involved in more acute and critical care medicine was just something that has always appealed to me. I think what ended up happening over the course of my medical training was that, I think you very rapidly acquire a sense that a lot of what you're doing is not actually curing disease or saving lives all the time, but really managing things and just trying to improve quality of life. And I think once you understand and embrace that, I think a transition to palliative care becomes very logical. Many people find it quite interesting. And we really want to be good at it because, when the goals are comfort, even when someone's dying, things can become quite achievable, and you can really, I think, make a good positive impact on someone's quality of life. I've found it a very gratifying career on many levels, and it pairs nicely with critical care because, again, you have to remember that, in palliative care, we are sometimes trying to fix illnesses when we can to improve symptoms and quality of life. And even when you're trying to save someone's life in critical care, you do always have to be involved in patient-centered goals of care discussions that are core to palliative care, and making sure people are comfortable, that they're not suffering. So I think the two of them, I've always found that they went nicely together. And now we have, I think there are more than 10, 12 Canadian physicians who are dually trained in critical care and palliative care, because I think they all felt the same way.
Yeah, that's great. So you have a really great stock of experience to speak to some of the questions that we're looking into in the Kernel Network and the different research projects. If you were to describe a day in your life on the job, how do you typically spend your time?
There's no really typical week for me. They're all a little bit different. So some of my weeks are spent on the palliative care service, and that might be doing consultations in one of our acute care facilities. I also attend in the palliative care unit. So there are times when we have patients who are just patients under the care of palliative care, which is different than consultation work, where you have somebody who's admitted to, for example, oncology, but needs help with some palliative issues, and that's where I get involved. When I'm in the ICU, that's a week in the intensive care unit. 7 days is pretty intensive. I don't do very many of those, but I do some of them. And then I have academic weeks, which as a division head, I have a fairly large division now, 40 people, so I have to do frequently meeting with people. Have a lot of junior people, very energetic and smart people who are starting really big, important research programs. And so I want to kind of meet with them periodically and help support them, figure out how I can help them along and mentor them advice, find them resources when I can, and try to make sure that they succeed. Those would be my sort of typical weeks. I do obviously have my own programs of research that I'm also involved in, and so my my other academic weeks might also include a lot of writing grants and papers, that sort of thing. And now that COVID, the pandemic's abating a little bit, back to travel. So I travel to conferences and stuff and give presentations.
So you do actually get some days when you can just sit down and quietly think about things and do some writing. That's good. That's good.
Well, I think that's obviously important, but I think, some of your best thinking and I think when you're involved in academic medicine, it's important to stay at least slightly in the clinical world, because that's where you get the greatest appreciation for what the challenges are and the questions that need to be answered. I think if I was not doing clinical medicine still paired to research, I'm not sure that I would necessarily be as good a researcher. I think being involved in both makes you good at both, makes you better at both.
Makes a lot of sense to me. And I've been talking to some doctors on this podcast, and I just repeatedly say that I'm a philosopher. I do research and teaching. I don't have the clinical side, but I end up thinking about these issues quite a lot, and I'm always very interested in talking to people who do this stuff live, like for real on the ground, and face a lot of the stuff that we're talking about, because I think that's probably a very different perspective on things than the comfortable classroom where you can just kind of debate things somewhat in the abstract, right?
Yes.
If you could talk a little bit more about your research, and I don't know if you could just give us a little bit of a trajectory up until the present time. What have you been focusing on, and where are you at right now, like on the research side of things? What's your main focus?
Yeah, I think the main stuff I'm involved in, I do some research in the critical care environment and have done research over the years that is relevant to end-of-life care. So decision-making and communication training. I also study bereavement and bereavement experiences for family members who lose loved ones in the ICU, and figuring out ways of supporting them. And we recently completed a trial of some symptom management medications and different symptom management strategies that would be helpful in another pandemic if we were, say, running short of anesthetic medications, which we did. And so that's finished. Most of my research, though, is in the palliative world, and I'm involved in supporting a lot of different programs. But the things that I'm mostly leading and mostly interested in myself, I'm very interested, first of all, in existential distress. And so this is the sort of, I think, a lot of what you want to get at and understand around medical assistance in dying, because it is the number one reason why people request medical assistance in dying. It's overwhelmingly number one. But it's obviously something we've known about long before medical assistance in dying was legal. And the impact of existential distress goes far beyond medical assistance in dying, that, even when your numbers have climbed to, as high as they have in Canada, it's only 3 to 4%. It's actually not that high at all. But the percentage of people who experience severe existential distress before they die is probably somewhere between 20 and almost 40% of the population. So again, the quality of life and the suffering itself is really the key feature, and it's extremely common. It's very burdensome. It is, for many people, the worst symptom they experience, and we have very, very little to offer. So trying to develop and study new treatments. So using transcranial magnetic stimulation. We've just finished a study looking at that, and we're submitting the results, very encouraging results. We're hoping to get a study of low-dose psilocybin going in the next couple of months. We've got everything through the regulatory hurdles, and we're just about to start that. That microdosing, it's called therapeutic microdosing, is very promising. Collaborating with others on macrodosing, so assisted psychotherapy, having a full-on psychedelic experience, that's super important as well. And so that's one big area of research that I'm interested in. I'm also interested in looking at newer techniques for treating symptoms and agitated delirium. So we're using new types of sedatives in the palliative care context that I think are very important. And then also as a holdover from my educational research that I did back in the day, was looking at newer ways to integrate and actually setting up systems to prompt people to assess for unmet palliative needs in specific settings. So we're I think becoming aware of the fact that really there are a lot of unmet palliative needs, but you can't simply tell everybody to assess everybody for unmet palliative needs. It won't happen. It's too much work and nobody will do it.
Mhm.
So trying to find ways, sort of automated, reliable ways of flagging people who are at high risk of having unmet needs. And a lot of this involves sort of augmented intelligence, computer algorithms to sort of automatically use existing data to sort of point out patients who might be at high risk and prompting clinicians to go and assess them and respond accordingly. So I'd say those are the big areas of research that I'm involved in.
That's all incredibly interesting. Could you tell us a little bit about existential distress, the nature of that? Because referring to existential distress as a symptom, I mean, the distress itself could be a symptom, but the adjective existential,
Yes.
what's sort of covered under that?
So it's a great question, and I think if you ask 50 people, you'll get 51 answers. There is no universally accepted definition for existential distress. I think in many cases we get a bit of a working definition of existential distress that we find helpful. So if I had to explain it to somebody, it's sort of almost like a sense that someone has lost their purpose or lost their sense of meaning, their personal sense of meaning, as a result, and in the context where I work, generally as a result of their illness. So their illness has done something to them that is now preventing them from performing the activities that would normally, from which they would derive the joy in life, but not just the joy and the fun, but the sense of meaning and purpose. So humans are relational beings. A lot of what we do, a lot of how we define ourselves and our purpose is in terms of the role that we play for others and the things that we do, in society. And when you get sick, when you get an illness, and that illness may be advanced and incurable, very commonly, you're no longer able to do those things. So your role can change, and it can change quite rapidly. And for some people, they're able to tolerate that and they can manage a role transition, and others can't. So they've experienced tremendous distress at the fact that they're not able to do any of the things that they used to do, and now they are in a role, for example, of receiving care, receiving supports. And some people are okay with that, and some people are really not. And so if you had to give it a sort of shorthand definition, I think probably the most shorthand or portable definition would be that someone's lost they've lost a sense of purpose or sense of meaning as a result of their illness. And would be the way to describe that.
And I was kind of wondering if another side of it, like, would issues about a sense of loss of dignity, loss of value, of a sense of worth, would that play in as well under the same rubric, or is it mainly sort of purpose, meaning?
Well, I think that a lot of the discussions around this, people use terms like sense of worth or sense, worthiness. And I think when you talk to individuals that have this condition, worth isn't the word they use. And again, obviously any discussion of medical assistance in dying is to a degree political. I think that for people who are opposed to medical assistance in dying, often there's a strong temptation to try to sort of hijack the language of eugenics, genocide, and the Holocaust. And so the concept of worthiness and being worthy of life, from Binding and Hacha and other sort of famous tracts of eugenic writings, this is an obvious attempt to, I think, draw comparisons between medical aid in dying and the Holocaust. I don't support any of that, and I think that if you even spent any amount of time studying eugenic writing, and spent any amount of time talking to human beings who are asking for medical assistance in dying, it just isn't that. They are just talking about two very distinct concepts. Closest I would come is to say that a patient will say something like, "It's not worth it." It's not that I'm not worthy. It's just continuing is not worth it for me. And so those are two very, very different statements, right? So that, again, if I have a condition that's not going to get better, that my loss of ability to do the things that gave my life and meaning and purpose are gone, it's not that I view myself as unworthy or somebody who shouldn't be here. It's just that my daily existence, my purpose, is just sitting here receiving care or watching things or being a museum piece for others to come in and visit when they can. That's not what I'm here for, right? That's not my purpose. So I don't really like it. They don't probably care two hoots what the rest of the world thinks of them, of their worthiness. They don't care. They only care about their own experience. And so, any number of family members will come in and say, no, but Dad, I love you. We support you. We still want you here. And then he'll say, okay, but that's fine. But, you're not living my life. Like, I love you guys and I want to spend more time with you, but this is not a life I want to live.
Right. Yeah. Okay. That's some good insight. I wanted to ask you one other thing that you brought up in talking about your research, and it's the psilocybin, the magic mushroom therapy.
Yes.
And psychedelic experience. Can you say anything about that, about sort of what the idea is about how a treatment like that might help to address somebody's existential?
Yeah, somebody's lost a sense of meaning and purpose. Why not just grind up a bunch of mushrooms? Because that'll fix it, right? I agree. I mean, there's nothing intuitive about this that makes any sense, and I don't think any of us fully understand, why, on a fundamental level, why certain things cause psychedelic experiences and why those psychedelic experiences in turn fix the problems. And I guess the question is, I can tell you what the literature says, and I can tell you a bit about the biology of it. So the idea, right, is that, if existential distress is essentially a gap between what gives you a sense of meaning and what you're able to do, right? So it's a gap between expectation and experience. There's two ways I can try to close that gap. One of them is I can raise your capabilities up if I can figure out a way to do that by curing your illness and making you better, which I can't always do. The other way is by adjusting your goalposts, and adjusting your set point, where your thermostat set point, which is what you're hoping to be able to do. I can't change what you're able to do, but if I can change the distress that you feel about that gap, or if I can reduce that gap psychologically in some other way, then I just relieve the distress, and that to me is all I really need to do. So, unfortunately, there aren't a lot of effective ways of doing that. There are psychotherapeutic methods that people use. Realistically, the data is not that impressive. Again, some of them do show benefit, but the benefit is sometimes modest and very short-lived in the studies. There are outliers, absolutely. There are definitely people who respond very well, and anecdotal stories of some people do very, very well. But on the whole, when you study this, the outcome isn't great. So the idea behind psychedelics are essentially that, okay, part of how the psychedelics work is that they change your sense of perspective on the world and what matters and what's important. And there are parts of the brain where that appears to be encoded. The tip of the temporal lobe, which is the semantic self, which is this personal sense of meaning. And those are connected. So that part of the brain is connected in certain ways to the frontal lobes and to other parts of the brain that assess your ability to do things and your needs and what's around you. And that network fires when you're in existential distress. So when the biology of this essentially seems to be that when it works and you get a psychedelic experience where this dissolving the sense of self, the barrier between what is the self and what is the universe, there seems to be a dissolution or a changing in the circuitry and the signaling, such that circuit doesn't fire as quickly, and thus perhaps and again I'm speculating a little bit, but is that just essentially your frontal lobe no longer checking in and constantly noticing that there's this giant gap between what you think you should be doing and what you are actually able to do? And if you can do that, that's sort of the logic there. But it really relates to feeling perhaps less distress around that gap, and does through a psychedelic experience being able to sort of question and break down your construct of the semantic self in ways that are important, right? So not that you emerge without any value whatsoever, but the things that questioning many of the things that you think define you, and now that they're causing you distress, maybe being able to remold those a little bit in ways that they no longer cause you distress.
That's incredibly interesting. So do you have some articles that'll be coming out in the near future about this sort of approach, or this sort of?
I would love to tell you that I'm about to publish it. I can tell you that we've been working really hard at getting this thing off the ground for a few years now. We got funding for this years ago, and then the pandemic struck, and so obviously it got punted down the line a little bit. But the regulations around use of psychedelics everywhere in the world, but particularly in Canada, are quite complicated and quite involved, and so it's not exactly a quick process. So we have basically spent 4 years trying to get this thing approved. And now we're at the point of being able to start. So again, I don't think we're going to have data back for a long time. We're going to be looking at microdosing, which is sort of something that not many people are studying. Most people are studying macrodosing and therapies around macrodosing, and psychotherapy around with macrodosing. And that's a very different sort of thing where all the recent published articles really focus on that macrodose. So we're hoping that perhaps microdosing, which because you don't need therapy and because people don't actually have a psychedelic experience, you can do this at home. You can do this theoretically without supervision, and that's obviously positive. But it's also very scalable, right? It's much easier to be able to give somebody a pill that they take every day than to have to arrange, a full day of psychotherapy with 2 therapists. So the scalability, it may not be we have no idea if it's effective or how effective it is. There's a lot of anecdotal reports that microdosing is very effective. Many people do it sort of recreationally. But and then they fill out surveys saying they do great, but that's not high quality evidence, just to be very clear. Like it's anecdotal. But we're trying to sort of fill in some gaps there in terms of our understanding of the effectiveness of these therapies.
Something to look forward to in the coming years, for sure.
I think so. I think we're going to get a lot more information. I think we're seeing that psychedelics have tremendous potential in treating a number of conditions. They're not the cures. They're not universal cures. Let's be very clear. There are occasionally safety issues, but the safety issues are very minor compared to many of the treatments that we use. It's very appealing to sort of rush to new ideas. So this is the new way. This will fix everything. We have to test this, we have to study this. And there have been some more recent studies suggesting that perhaps our early results might have been a bit exaggerated and not necessarily, we're not seeing the same level of effectiveness that we once saw. But that's why you study it, and maybe we need to tinker with it. It's not the question of does it work or does it not work. It's how do we optimize it.
Something like existential distress being such a large part of the negative experience that people are having, it seems like it's a really great idea to be looking into some creative ways of addressing that. What can you do about that, right?
Well, and I mean, existential distress itself is not limited to end of life. It's not an end of life problem. It's existential distress you can experience at almost any moment of transition in your life. So classically, loss of job, loss of a life partner, divorce. People very often, and of course, adolescents, teenagers growing up and sort of in university and looking to find your way and find your purpose. These are issues that come up all the time. And so the idea, again, and being able to help people cope with that, don't have to be dying to deserve good care, that I think is very appealing.
I mean, you could say to some extent the same thing about palliative care in general, right? That people encounter all kinds of suffering and pain and symptoms associated with difficult things that could be addressed, whether they're dying or not. But I get it. Yeah. Well, that's awesome. That's super interesting. Thanks for sharing all of that.
Well, you're most welcome. I mean, again, and I want to be very clear, right? Like this is. In the context of some of the research that you're doing and that you and I are working on related to medical assistance in dying. It is the number one reason people request this, and that gives you some idea about why this is so severe, right? Like people often think of, the thing they fear the most as they approach end of life being pain or nausea or shortness of breath, physical symptoms. But it's actually, when people have existential distress, it is almost invariably reported as the worst symptom that they have, not a physical symptom. And so that's why it's important for all of us to be on top of this and be aware, and again, understanding that the purpose of doing research like this is, for some people, it's important to try to do everything we can to prevent somebody from requesting and receiving MAID. I personally don't look at it that way. I don't think my purpose is, I'm not that concerned with how many people are, as long as you're competent and you have your options and you're making a competent to capable decision. I am very concerned with doing everything we can to stamp out suffering, and the idea that we can stamp out suffering, can reduce MAID is interesting. But MAID is only even a tiny minority of people with severe existential distress even seek out MAID. So it's 9 out of 10 people with severe existential distress aren't asking for MAID. We need to address their needs too, right? That's a super important area, I think, for us to focus on.
Yeah, and sort of related to that, just the big picture of the kernel network, of which this podcast is a part, is to think about, what is contemporary end of life care like in Canada, also beyond. We tend to focus mainly in Canada, but also discussing ways that things could be made better and what we could be doing about it. So, like in your work, you've talked about a lot of different angles of improving end of life care, a lot of facets of end of life care that you've studied and considered. If you were to take a step back and just ask yourself, okay, currently in Canada, what are, say, 2 or 3 of the most significant challenges that remain to being able to provide excellent end of life care to people who need it? If you were to try to identify maybe 2 top priority issues, what would they be?
Yeah, I mean, I think that broadly speaking, improving end of life care in Canada, the broad categories would be the quality and the quantity, right? So we need to, I think I think people do comment often that there are many people who still don't have great access to palliative care, and I think that's true. I don't think the numbers are as bad as sometimes the numbers that are put out are often, numbers from 20, 30 years ago. More recent data suggests that actually, the majority of Canadians are receiving something that you could consider palliative care, and that those numbers are climbing very quickly, certainly in the past 5 and 6 years. Governments are making very substantial investments in palliative care and in home care because they recognize how important this is. That is an objective fact. That's not an assertion. That's been demonstrable. My division, for example, I have a division of 40 physicians. My division has doubled in size in the past 5 years. It's almost certainly the fastest growing division, academic division in all of Ottawa. But it's got to still grow. We still have to grow more, and we also have to grow in certain areas. So supporting more rural areas, making sure that we have better capable home care. More growth in services available in the home setting, and the ability to provide the ability to fund hospices, for example, and set up more community-based areas and community-based facilities where people can go for end of life if they can't go home. They can't stay at home, but don't really want to go to hospital. So those are the big gaps. I think also, though, we even people who get good palliative care, a fairly substantial proportion of them still suffer and suffer in physical symptoms, things that we are generally is our strong area. Because our treatments are not perfect. There's still quite substantial gaps in what we can do. So there is definitely an access gap. There is a quality gap. That's why we do research. That's why we study things like psilocybin and RTMS and all sorts of other things, is to try to close that gap. And I think identifying better pain control techniques, every field of medicine has to, is engaged in the process of developing better techniques. And I think that's a big, important area for us too. And we've been very successful. Again, the past couple of years, we created a pan-Canadian research collaborative that focused on palliative care. And we've been able to get some clinical trials off the ground, multi-center trials, and hopefully setting up a platform where we can study all sorts of things. To try to close the gap, to try to meet, to fill these unmet needs.
Awesome. Yeah, lots more we can talk about there. I did have one other sort of specific question that I'd like to get into with you a bit in the time that we have remaining here. That you mentioned the research that you and I are kind of connected on. And one of the big questions that I've been trying to look into has been, how has medical assistance in dying been received within the Canadian palliative care community and more broadly the end-of-life care medical communities in Canada? My impression is that people are still pretty divided on issues like whether MAID should be officially included, recognized as a component of palliative care. Some end-of-life care providers feel that MAID should be kept separate. Okay, it's a thing, but it shouldn't be part of palliative care in a formal way. Others think palliative care should just fully embrace it. And I'm wondering, like, could you tell us a little bit to what extent, in what sort of capacity have you been involved in that sort of issue, and what sort of insight do you have into that, given your...
Yeah, I mean, I can tell you that, there's in Canada's one experience, obviously there are others to draw from. I mean, there's a strong antagonistic relationship at times between MAID and the practice of MAID and the palliative care community. So I was definitely an oddball when I sort of 10 years ago, I guess now came out of the closet, as it were, as somebody who felt that this is something that we could and should legalize. And but in the past 10 years, a very substantial proportion of palliative care providers in Canada have come out saying the same thing. Since legalization, I think the broad impression is that people have realized that it's, the two can definitely exist alongside one another. And, there are many hospices across the country that started off with an absolute blanket ban on the practice of MAID. The large majority have, of their own accord, changed their rules based on their own experiences, and that they just found that their patients, they were doing the best they could, but sometimes their patients still wanted it, and they didn't have an obvious argument against it, and they could bring somebody in to do the procedure, and it didn't actually affect other people and didn't destroy the character of palliative care in any way. I would say the common concern is that when MAID is legal, that it detracts from palliative care, that you won't get the funding, that everyone will just decide we don't need to fund palliative care, we'll just go for MAID. It's hard to imagine a 5-year period in Canadian history where there has been this strong a growth in funding for palliative care and the provision of palliative care. And that's despite the pandemic, right? That we saw recently a High report released showing an incredible growth in the number of people getting palliative care before they died, people dying at home with palliative care, more than doubled in the past 5 years. So, these are, and again, the huge involvement, it's often pitted as an either or, that you either get palliative care or you get MAID. In fact, the large, about 80+% of people who get MAID were followed by palliative care, many for weeks or months before for weeks or months before they got MAID. So again, it's a false dichotomy. There isn't a choice. And sort of 98% of people who got MAID either received palliative care or had access to palliative care in the assessment of the providers. When you look at the populations that get the most MAID, they're the populations that get the best, earliest palliative care. So cancer, patients with cancer, et cetera. Have always gotten the best palliative care, and they have the highest incidence of MAID, and they don't have more suffering. That no metric has ever shown that they get more suffering than non-cancer patients. So there's something obviously there, and it's not a competitive thing between MAID and palliative care. The two could be provided side by side, and it doesn't really affect that. While we definitely have room to improve, the timing and the overall availability of palliative care, right? We should probably be giving it to more people and giving it earlier. When you look at the numbers among the people who receive MAID, I think, broadly improving palliative care, we should do that for the sake of Canadian society. But broadly improving the quality and the timing and the availability of palliative care will probably have almost no effect on the practice of MAID in Canada, because it's not a lack of palliative care that's driving it.
Again, thanks so much for all your time on this. I don't know if you have a minute for one last follow-up.
Yeah, of course.
So I'm hearing you talk about this, and I guess when I've been approaching the issue, I've been sort of trying to see it as a debate where there are two sides that people really have legitimate points on different sides as to why palliative care, there might be good reasons to include MAID, or there might not be. And what I hear from you is that really you don't see a lot of grounds on the side of people who are saying that MAID should not be part of palliative care. But are there? Is there any good reason why somebody might be opposed to that?
Well, I mean, a religious and moral one, I think. I want to be very clear that, the moral debate around medical assistance in dying and what is the purpose of suffering in life, right? Is suffering something that we can and should do pretty much anything to eliminate in somebody, right? Like that's a very important moral question. And so, and we can get down to the nitty gritty. Now, is the debate about policy, is the debate about eligibility criteria, is the debate about safeguards, is the debate about oversight? Those are questions for which there are often factual points to discuss and grounds for discussion. And then there's the moral question of whether we should do any of this at all. Or whether the moral question of whether it's justifiable in terminal illness, but not justifiable in non-terminal illness, or whether, administering something, a physician administering a drug versus handing somebody a prescription that they take themselves, is that a moral distinction that we recognize and think is important? So these are the kinds of questions that I think there is a lot of ground for moral discussion. And I definitely think there are very legitimate discussions that I've had with many of my religious friends on this.
I think that someone like yourself who has so much awareness of what's going on from the inside, it's really helpful to have somebody who can speak to those facts and speak to what's actually happening. And I think you've shared an enormous amount of wonderful stuff for our audience today, and I'm really thankful for your time. Thanks so much, James. All the best to you and all you're doing.
Likewise. Take care, Andrew.